Shall we start, Pa? Good afternoon, everyone. This is the first time in 2015 we are going to have a webcast of the PG teaching program under the auspices of the Indian Academy of Pediatrics, supported by Alembic. This program, which was started last year, is continuing this year, and this is the first time in 2015 we are going to have it in our institution. Today we have a unique model for this from our institution. We have two presentations. Is that right? We have two presentations. The first will be by Dr. Samira, our DNB Final Year PG. The second will be by Dr. Malesri, our Final Year DNB PG. The faculty will be Dr. Ganesh, our junior consultant, Dr. Dhanlakshmi, our registrar in pediatrics and infectious diseases, and Dr. Sumant, our registrar in pediatrics and pulmonology. And we will start the session with Dr. Samira, who will be presenting details of an adolescent boy with a respiratory problem. Is that right, Samira? Yeah, please come.
Good afternoon, everyone. I am presenting details of Varun, 10-year-old male child, hailing from Chennai, attending schools regularly in 4th standard. Information given by the mother, and it is reliable. The child was brought with complaints of fever since 6 days and cough since 4 days. Child was apparently normal, and he developed fever 6 days back, which the fever was documented intermittent in nature, 2 to 3 fever spikes per day, not associated with chills. Cough since 4 days, which is insidious in onset, progressive, with no diurnal variation, not related to position, and no aggravating or relieving factors. The cough is not associated with chest pain. The cough is associated with white color sputum, which is small in amount, about a spoonful of quantity, not foul smelling, white in color, not blood tinged since last 2 days. No associated fast breathing, noisy breathing or chest pain. No difficulty in breathing, dyspnea or chest retractions noted by parents. There is no past history of wheezing or no history of use of nebulizations in the past. There is no history of swelling in the neck, difficulty in swallowing or change in voice noted. There is no history of cyanosis, palpitation, breathlessness. He is able to perform day-to-day activities, and prior to this episodes of the illness, he was playing with his peers well. There is also a history of associated decreased intake since last 3 days, and non-bilious vomiting since last 2 days. 2 to 3 episodes per day, mostly after taking medications, with no associated abdominal pain or loose stools. There is no history of recent travel. There is no history of dysuria, earache or ear discharge. There is no history of joint pain or rash. There is no history of swelling in the limbs or the abdominal distension. No history of seizures or altered sensorium. Child has been admitted outside for past 2 days and referred here in view of persisting fever and cough. And the child has not required oxygen supplementation. There is no past history of hospitalization in the with similar complaints.
Stop. Samira, just a few clarities. You said fever. How high was the fever?
So documented fever was 102, sir.
You said about history of abdomen distension. This is a boy who presents with acute onset of fever and a cough.
Yes,
what is the relevance of abdomen distension, history of recent travel with your particular patient?
Sir, he has mainly presented with fever of long duration, the 6 days, and cough since only 4 days.
Fever of 6 days is not of a longer duration.
Yes,
Okay,
sir.
you call prolonged fever and fever lasts for more than 10 days.
10 days.
Okay, fine. So what are the different, what system is involved from your history?
My history mostly such of respiratory system involvements.
What parameters make you to think it is of a respiratory system involvement?
So associated coughs and sputum production. Yes, sir.
Okay.
Sir, it helps to signify the color and the quantity helps to signify the underlying disease.
Okay, based upon the color of the sputum, what underlying etiologies will you think of?
Sir, rusty color is seen in associated with pneumonia, pink color in pulmonary edema, or anchors are in suspected abscess, maybe abscess.
You said there is no history of seizures, right?
Yes.
In this particular patient, why the history of seizures becomes relevant? Your negative history should be able to bring in the etiology, the risk factors and the complications. Okay, it's not as routine you have to take a negative history. So fever for 5 days, a cough for 5 days in a big boy, right? What is the relevance of seizures?
Sir, in cough in a elderly boy, speaking of even atypical infections like mycoplasma or chlamydia, so I'm thinking of other complications.
That's fine, but what is the relevance of seizures? Do you think a 10-year-old with a short history of 5 days history of fever causing seizure? That means you are considering two systems here.
Sorry. No, sir.
That means if pulmonary is the main system, the only way a pulmonary system can manifest as a seizure could be a hypoxic seizure. But it is not very common in this age group and the child is not also so toxic. So that is what Dr. Ganesh was trying to point out. The negative history, try to get at some etiological or pathological or complicated diagnosis. Otherwise, just like that, don't ask for it. And he was asking about another thing I too wanted to ask. What about the relevance of history of travel? Why did you mention that in particular in negation?
Sir,
did you have something in mind by asking a history of travel to some place? Is there a possibility of a pulmonary infection getting contacted by the patient at 10 years of age? I agree with you. For example, if you are dealing with a case of scrub typhus or a malaria, he has gone to an endemic region, or a dengue, even simpler things, then I agree. But here you told very clearly, you are right also in telling that you are dealing with the case of respiratory system and the symptoms seem to be acute onset with 5 days history with cough and cold with respiratory distress. So that's what I am asking you. What was there in your mind in asking about the relevance of travel?
Travel history only I asked to rule out negative factor for other causes of fevers,
okay,
not with respect to respiratory infection.
Okay, fine. Right.
Chief complaints after elaborating your chief complaints, you said it's a respiratory system involvement. Are you able to exactly classify whether it is upper respiratory or lower respiratory? Have you had any clues for it, whether it is an airway involvement or a pleural involvement or a parenchymal from the way you elaborated your chief complaints?
No, sir, it is according to history there's less chances of pleural involvement because there's no associated chest pain, okay, or no preference to sleep on one side, or okay, no diurnal variation,
okay,
or no pain while coughing. So
okay,
it's less likely to be pleural involvement.
Less likely to be pleural involvement. From your chief, from the history of your presenting illness. Fine. Then what about parenchyma?
Parenchyma and airway I am not able to differentiate by the history, sir, because there's no history of fast breathing noted, no retractions noted, or hypoxia noted, or no history of wheeze.
Hypoxia is a physical examination finding, right? Okay, unless the child has got gross bluish discoloration of the extremities, you cannot classify hypoxia. It's a physical examination finding, right? So from your history, what are the parameters to point out whether it is a parenchymal involvement or whether it is an airway involvement? I say this is a wheeze.
Samira, what are the travel-related infections which can cause respiratory problem? Since you said negative travel history, but the audience can also answer. What are the travel-related respiratory?
Actually, this is the way many students invite questions from the examiner.
Though not related, suppose.
since he mentioned specifically negative history of travel related. Anybody in the audience who wants to? What are the travel related respiratory infections?
H1N1 now.
Pardon?
H1N1.
Yeah, very importantly in H1N1. Now what is raging throughout the world? Ebola. What
Then-
else? What else?
Pardon?
What else can come from travel? Respiratory problems. Malaria, yes. Can malaria present with cough?
Yes.
Can it or not?
Yes.
Which type of malaria? In fact, in the past, there have been reports that the commonest symptom of malaria in Bihar was fever and cough. So it can present, and particularly falciparum malaria, which can cause, what can it cause in the lung? ARDS can come out of malaria. Right. What else? Any other travel related respiratory infection?
Pardon?
Anything else?
Middle East.
Suppose the child had gone for swimming outside in a resort and comes back. After swimming, what can happen? But even leptospirosis can present at the ARDS. That's not the commonest one, but cough is not the prominent symptom. Leptospirosis can cause even your unusual pneumonias, which can come. Which pneumonia can come after drowning or near drowning rather? Near drowning, somewhere in the east, fungi are there. You can get unusual fungal pneumonias also secondary to near drowning or due to after swimming, right? So these are all the possibilities that you have to think of. Sometimes they report that enough is not common in pediatrics. They report even Legionnaires disease, which can come after travel. It's supposed to come through air coolers or air conditioners. So they can be contaminated, and the child can very well develop Legionnaires disease following a travel. Right? The next thing is, Samita, can you tell me the explanation for this child having fever for 3 days, then cough, then getting hospitalized? What do you think is happening in this boy? What is your interpretation of the whole history? Ganesh was asking whether it is parenchymal or pleural or airway. Still, what is the predominant symptom in this child?
Fever.
In addition to fever, what is the next important symptom?
Cough.
Okay, from the history, there is nothing suggestive of any rapid breathing. Retractions are not there, and questionable expectoration is occurring, isn't it?
Yes.
I think the rusty sputum of pneumonia, I don't know, I have never seen a rusty sputum in any pneumonia in any age so far. How many of you have seen rusty sputum described in books? Very unusual. Some things, many things which are very common in adult medicine like hemoptysis, rusty sputum, paroxysmal nocturnal dyspnea, all these things don't occur in children. Even in older children it doesn't occur. It's not, even if you see hundreds of pneumonias, you hardly get rusty sputum. Right? What is the quantity of the sputum?
About a spoonful.
About a
Spoons.
About a spoon. Do you think it's significant? What does it signify? A spoon of sputum with cough, a few days of fever. Do you still think this is only an airway problem, or do you think it's a mixture of airway as well as a parenchymal problem?
Mixture of airway and parenchyma.
Mixture of a
Airway and parenchyma.
and parenchymal problem. Otherwise, why should the child have prolonged fever? The other thing is, what has happened to the fever? See, basically, in respiratory system, it's very, very useful to remember a simple mnemonic. I remember it as PQRST. Right? P means, what is P? Anybody? What does the mnemonic PQRST stand for? We will start from P. P means timing of the symptom. For example, a cough which is there only during daytime and it is not there during night time. Obviously it's a psychogenic cough, and the reverse is an airway cough, isn't it? That's number one, timing. Yes means severity. How severe the symptoms are, how severe the cough is. Is the cough increasing, remaining the same, or decreasing, Samira?
Cough is increasing.
Huh?
Cough is increasing.
Cough is increasing. Okay, that's very important. In some children, initially there will be cough. If in a given child cough is there, the cough decreases, but breathlessness increases. What does it mean to you? Initially what started off was a bronchitis resulted in a parenchymal involvement, because the moment parenchyma involved, cough doesn't become prominent, breathlessness occurs. That's the usual story you get in most pneumonias. Right? Initially the child will have cough, fever will persist, fever will increase, but the child will stop coughing, will start becoming breathlessness. So severity, PQRST. Right? R means what? What is R? Radiation. Any symptom, you have to find out whether there is pain, whether it is radiating to a particular place. Right? What is Q? PQRST. What is Q? Quality. Very important. Now we talk about quality assurance and development, isn't it? Quality. Where does quality become important? Which symptom quality becomes important? Samira described vividly some symptom. What symptom?
Sputum.
Quality of what? Quality of cough. In fact, I never heard Samira describing the nature of cough. Did he, Ganesh? Is it important? Can cough give a diagnosis to the etiology? From the audience, can you give examples of cough giving clues to diagnosis? You can, from the way the mother describes or from the way the child coughs, you are going to get a clue that to the diagnosis. Can you give some examples?
Whooping cough pertussis.
Obviously, whooping cough. Remember, no fever, only cough, no other symptom, right? No chest signs. What is the diagnosis? You will miss the diagnosis if you don't know the quality of the cough. Right? That's important. So Q. What does P? P stand for? Progression. And then what is the other P? What is the other P? Progress of the symptoms. One more. Periodicity. Progress, periodicity. For example, this is very important. I'll tell you. For example, when I asked him about the cough keeps on improving. That means something sinister is happening, is worsening. The cough comes down, some other symptom appears, something else is happening. Or the cough comes and goes. What's the diagnosis? Cough comes and goes. First few days cough, disappears. After 1 week cough, then breathlessness. What does it tell you? In airway disease again, what is the commonest cause of recurrent cough in pediatrics, or for that matter in adult medicine? What is the commonest cause of recurrent cough in pediatrics? Hyperreactive airways disease, asthma. Right? So this PQRST has to be applied to any symptom, not only respiratory as well as any. If you apply this, now Samira should tell us whether this is a respiratory problem first of all, and then I'll request Ganesh to go into detail about the nature of the respiratory illness that we are dealing with in this child.
So at the end of your presenting complaints, what problem? Have you identified there is a problem?
Yes, sir.
Okay, so there is a problem. If there is a problem, which system is involved?
Respiratory system.
Respiratory system is involved. Fine. If it is a respiratory problem, is this an acute problem or this is a chronic problem?
Acute problems.
Acute problem. Fine. Once there is an acute problem, now where is the problem?
Probably.
You have got 2 lungs, right? So now where is the problem? From your history.
Cannot make out on this.
Okay, so you cannot clearly localize either one lung is affected or both lungs is affected. Fine. Now, if there is a problem, now which portion is involved? Whether it is an airway, whether it is a pleura, or whether it is a parenchyma.
Probably airway and parenchyma.
Okay, in this particular patient, it seems like there looks like to be a mixed problem. Okay, because one, to call it as an avid, the child predominantly has got a cough. Then second, to call it as a parenchyma, the child has fever. From your history, we cannot clearly get into whether the child has got tractions, whether the child has got any fast breathing, whether the child sputum is more of productive nature, or any other chest pain which we cannot be able to localize. Fine. Now, if there is a problem, now what is the problem etiology you think of? Is this going to be a bacterial? Is this going to be a viral? Is this going to be a fungal?
Probably I think of bacterials.
Probably you
Older
think
child.
of bacterial. Why?
Older child, so presenting with fever.
Even in older children, the most common thing is viral LRI first. It doesn't, unless you see a definite consolidation pattern on the chest X-ray or your auscultatory findings are giving a specific clue about a bronchial breathing which suggests underlying consolidation, you are not going to commit on a bacterial, right? So most common things first. Right now, it is probably of infective etiology, and how far by just with this history of present illness you are about to tell that it is a bacterial, it's quite enigmatic right now.
Dhanlakshmi, can you elaborate how with this you can differentiate whether it is likely to be viral, whether it is likely to be bacterial, and if it is bacterial, whether it is likely to be typical or atypical?
We can probably cough is a predominant symptom in viral LRI, sir. So more cough, more likely it is likely to be viral, and high grade fever is unlikely to be viral. It's common. More than 1 or 2, sir.
Okay.
More than 1 or 2, and there is no chest pain. Then we have to go ahead with the examination finding, and with the investigation only we can clearly differentiate.
But there can be other clues like
Like other system involvement, other mucositis like conjunctivitis, diarrhea, other system involvement favors more of viral etiology rather than bacterial etiology. And if there is extra pulmonary manifestation like pallor, rash and altered sensorium, it favors atypical rather than bacterial, typical bacterial etiology.
suppose other family members have got
Viral.
viral.
And more
Noisy
of
breathing is there, is likely to be, I mean, the chance, if a
I
child
carried it,
has cough and noisy breathing, which one is more likely,
Viral is
bacterial
more
or
likely.
viral?
Viral is more likely.
Yeah.
In
There are some
presence of
clues. Basically, if more than one family member has got
affected.
symptoms,
More than one system is affected.
one mucosa being involved, more than one mucosa is involved, more than, one member of the family having multiple
And seasonal
symptoms.
variation like H1N1 can come in epidemics.
Yeah. So that can differentiate, but it's not always possible.
Possible.
Particularly young infants, it may not be possible. In this child, with
More
this,
likely looks like bacterial only, more high grade fever, and cough started after 4 days of fever.
Samira, did you think of tuberculosis in this child? Fever for nearly about how many days now?
7 days.
7 days.
Totally 7 days.
7 days, fever, some cough is there. We'll say TB is very common. Could it be tuberculosis, Samira?
We'll ask audience. Will you think of tuberculosis, probable tuberculosis as one of the etiology in this particular context? If so, why? If no, why not?
Sir, symptoms, sir.
Okay. Acute
for-
onset favors.
Not favoring TB, sir, tuberculosis. Rather than bacterial.
Okay. Contact with TB, no history of contact with TB. Can you exactly define what a word contact means?
Sir, anybody in the family members or any person, child has contacted, has taken treatment for tuberculosis in the last 2 years.
Of tuberculosis. Okay. Are in adulthood, takes treatment for an open case of tuberculosis either recently or within the last 2 years. Okay, so everything should fulfill the definition for contact. Okay, fine. Then there is no history of contact. Okay, he has not come to that point. Probably he has the past history. Yes. Then any other points which favors towards or against mycobacterium?
The presence of any lymphadenopathies, the presence of any lymph nodes.
What else? What else? In a country like us, when will you suspect tuberculosis? To be more simple, when will you suspect TB? A cough for 5 days, will you suspect TB? Or beyond what duration you think in terms of tuberculosis?
Cough beyond 2 weeks.
2 weeks.
Okay, cough for beyond 2 weeks. Then fever?
What are the three cardinal symptoms when you suspect tuberculosis?
Evening rise of temperature.
Evening rise of temperature. Fever. Cough for more than 2 weeks. And loss of appetite. These are the three things.
And loss of weight.
Okay, fine.
Samira, do you think history of foreign body is relevant in this case? Acute onset of symptoms only 5 days. Can you reasonably rule out it is not a foreign body?
So it can be a possibility, but being an older child and also fever preceding the onset of cough is less likely to be a foreign.
Exactly. Fever appeared first and not the respiratory distress, or there is no paucity of symptoms in between. So, excellent.
So can you go present the past history?
There's no past history of hospitalization with the similar complaints, no history of nebulization, use of nebulizations, no history of contact with tuberculosis. Coming to antenatal histories.
Okay.
What past history is relevant in a child who has got pneumonia or who has got a lower respiratory? You said initially likely to be a bacterial respiratory infection. You said it could be a pneumonia, isn't it? That's what you said. So what relevant past history you obtain? You have a child whom you think with the end of the history that this is likely to be pneumonia. So what important past history questions other than of course tuberculosis you ask?
History of recent viral infections like measles, smallpox.
Smallpox has been eradicated.
Chickenpox.
Okay.
Just cool down.
Apart from smallpox, what disease has been eradicated successfully?
Polio.
Poliomyelitis. Okay, fine.
Is there a relevance of the similar disease in the past? Could this be a recurrent pneumonia?
Could be,
but carries quite significant.
He has made a mention that there was no similar history and there was no history of hospitalization. Apart from that, what similar history have you elicited?
In fact, to me, the most important question that I would ask in the past history, I would repeatedly ask for history of wheezing. The reason is, not only breast history, the commonest identified predisposing factor for pneumonia in pediatrics is an airway disease, asthma. Remember, the commonest, because pneumonia can occur even in a child who doesn't have an airway disease, but commonest identified factor for occurrence of pneumonia in a child is asthma. So you should go all out to establish or exclude asthma as a predisposing factor in this child. I think that too, in a 10-year-old boy comes to me with possible pneumonia, I would question the family repeatedly about the past history of wheezing episodes.
Whether it is acute or chronic, something you should ask. What?
Pets or
smoking in the family. I think that's extremely important. Studies have shown that the incidence of pneumonia, incidence of asthma, airway disease is definitely higher in those who are exposed to passive smoke. Extremely relevant. In fact, if you have a 15-year-old boy, even personal history of smoking also could become
significant,
relevant, however uncommon it is. Right? What What is your inference at the end of the history?
Could you please summarize? And with regards to the socio-economic scale, what the modified Kuppuswamis you are using, the 2013 version has been updated. Okay, so you can please refer the website and you can download the modified Kuppuswami scale. They have categorized the income to different way. Okay, right.
They have upgraded the
amount per capita income. Previous, now the 2013 guidelines have come. Okay, right. So could you please sum up, Samira?
Sir, this is a 10-year-old male child who was apparently normal before, has now presented with short febrile period of 6 days, followed by cough since 4 days, associated with sputum production, with no associated coryza, chest pain or respiratory distress, and no symptoms of cardiac involvement. I suspect possibility of a respiratory tract involvement. As fever preceded cough and severe enough to consider admission, I think of lower respiratory tract infection. With sputum production, I think of lower respiratory tract infection, mostly involving airway and parenchyma.
Okay.
Now, what are the lower respiratory tract infections you know of? How do you classify lower respiratory tract infection?
Depending on the
how does WHO, you know, all of you are familiar with the ARI program of WHO, right? How does WHO classify lower respiratory tract infection? Any idea? Anybody in the audience?
Audience.
May look like an undergraduate question, but then it is relevant. It is important even for a practitioner or even somebody in a tertiary care setting.
So, no pneumonia and severe pneumonia.
Pardon?
No pneumonia, and severe pneumonia.
Severe pneumonia.
Very severe pneumonia.
That's all, is it? That's all. LRTA, that's all. Only pneumonia. Other than pneumonia, there is no other lower respiratory tract infection. No, only pneumonia. All of you know only one lower respiratory tract infection. There are no other infections. What is lower respiratory tract? What is upper respiratory tract? What do you mean by URTI, LRTI? How does WHO differentiate URTI and LRTI? Anybody? Remember, larynx and below larynx, any infection is considered as LRI. Above larynx, by definition of the WHO, it is called URI. Because some books, some textbooks include laryngitis in URI, but the WHO clearly says larynx and below larynx it is LRI, above larynx is URI. As far as URI is concerned, you have pharyngitis, you have nasopharyngitis, you have otitis media, sinusitis. Right? As far as lower respiratory tract infection is concerned, laryngitis, laryngotracheobronchitis, that is croup, acute bronchitis, though the WHO doesn't use the term acute bronchitis, but textbooks do give so-called viral LRIs are all acute bronchitis. It's not, we are not used to, physician, we pediatrician, we don't write the term acute bronchitis as a rule. But many of these children who have cough, who have fever, with or without wheeze, they are all actually acute bronchitis. They don't have pneumonia. Right? After bronchitis, you have bronchiolitis. And bronchitis and bronchiolitis are clubbed together as the so-called viral episodic wheeze. And then you have pneumonia. Right? Then pneumonia obviously includes empyema. That's how the WHO classified the lower respiratory tract infection. Lower respiratory infection, not tract infection, it's lower respiratory infection. And what infection is this child asking? Is this child having, Samira? Is it laryngitis?
Bronchitis.
Bronchitis. You think this is bronchitis? Bronchitis. How often you have a child who has bronchitis, who have fever for 10 days? Which bronchitis causes fever for 10 days?
By bronchitis you mean only bronchial involvement or parenchymal involvement is also there? That's what sir wants.
Both parenchymal and airway also.
So what parenchymal involvement is there? Okay, I'll put it this way. A child who has what looks like a bronchitis continues to have fever, and the fever does not subside, the cough does not subside. He is an older child. With the history, you do not have the retractions and tachypnea. What complication of bronchitis is likely to have set in that child? Anybody in the audience? You understand my question? Yeah.
Probably.
You all buy the story of Samira saying that this is bronchitis? How many of you have seen bronchitis with fever going on, child getting hospitalized because the child is not improving? Why all of you are keeping quiet?
Sir is giving a clue about whether child is going into any complications as such, or is it just bronchial involvement or parenchymal involvement? What complications can you expect with fever going on like this?
Effusion and empyema.
Yes, tell Samira.
Complications of effusion and empyema setting.
Yeah, obviously. See, simple. If a child has an initial lower respiratory infection with bronchitis, the bronchitis can lead to a pneumonia. That itself can cause persistence of fever and that can explain the non-resolution symptom. That is number one. Second is, if the fever is not subsiding in spite of treatment, it is very likely the pneumonia which has occurred has also resulted in some secondary complication, which can include what? What are the complications that can develop? Suppuration, either in the pleura or in the parenchyma per se. In fact, in an older child, if the history suggests that this child is toxic, high spiking fever, 104, 105, not subsiding, he is still on antibiotics, he doesn't have pleural signs, what other complication will you think of?
Abscess.
Lung abscess. Suppuration. That's what I would have thought of in this child. Either this boy who had what looked like an airway involvement has developed some complication in the parenchyma, or he has resulted in this, or the primary problem has resulted in suppuration or a pleural complication. These are the possibilities. Third possibility is this is not behaving like the so-called typical pneumonia where you have very high fever, tachypnea, acute onset, recovery very fast. That has not happened in this. So it may be an atypical pneumonia. So this is not a simple bronchitis. With this history, if we say this is bronchitis, that makes it extremely unlikely. I mean, one should be wary of making a diagnosis of bronchitis per se in particularly older children, unless there is some noisy breathing or only disturbing cough. Only then you can make a diagnosis of bronchitis. Otherwise, one should not make a diagnosis of bronchitis. Right? Okay. Now, what about the treatment details of the child? Samira, that was missing. That's very important for me. A child who has had fever for 10 days, who doesn't seem to improve, the cough doesn't seem to come down. Would treatment in the past affect your assessment?
Yes. So mentioned the child had been admitted the fourth day of fever for 2 days outside, so received IV antibiotics.
Which antibiotic? Is that important to you? Does it make a difference in terms of your diagnosis as well as your treatment plan?
Yes, sir.
Yes or no?
Yes, sir.
Why? How? Anybody in the audience? See, he says that this child was admitted outside, treated for 2 days or 3 days. How many days?
2 days, sir.
Day 4 he was admitted. He was treated outside with the IV antibiotic. How does it matter to you in your assessment?
Either
anybody? Yes, Samira, you yourself can. answer or others? Anybody in the audience? I'm going to pick out. I think you people are all keeping quiet. Yes, Malleshwari, would you like to come and answer? Come.
In spite of the antibiotics, still has fever. Probably it's a serious infection. One possibility.
In other words, I am putting the question differently to make you understand. You have a child with, say, pneumonia. The child is receiving some antibiotic for 48 or 72 hours, or even ID consultants will say how many days? 4 days. 4 days. Okay, 3 to 4 days. You give antibiotic. You think you have chosen, you have hit the bug hard, and the child doesn't seem to improve. What is your inference at that point?
Either resistant organism, complicated.
One is resistant organism. Can you give an example of a resistant organism?
MRSA.
MRSA, very good. It could be a resistant organism, or it could be even a rare case of a pneumococcus resistant to your penicillin. You might be giving amoxicillin or amoxiclav. It may not be working. Good, very good. That's one possibility. Number
serious
two.
With complications.
What do you mean by serious infection? Every pneumonia is a serious infection to me.
Either necrotizing pneumonia, lung abscess.
Necrotizing, a lung abscess. Obviously, it won't respond in 2 to 3 days or even 2 to 1 week. Good. It could be necrotizing pneumonia or lung abscess. 2, 3.
Atypical organism.
Atypical organism. 3, 4. Viral. That means I was wrong in my diagnosis, isn't it? That means I was wrong in my diagnosis. So what's the first? Wrong diagnosis. First is wrong diagnosis. It may not be pneumonia. It may be a space-occupying lesion, or it may be a foreign body which is being treated as pneumonia, or it may be a tumor. Right? So wrong diagnosis, resistant organism. Third is, she said, pardon, complication. Complication, like empyema. Your antibiotics are not going to bring down the fever. Empyema, parapneumonic, sympneumonic effusions, right? Necrotizing pneumonia. What else?
Wrong dose and route.
Atypical organism. What else?
What about the host response? Will the host response be adequate?
Immunocompromised.
Immunocompromised children. Last. One more. Pardon? Wrong dose, wrong choice of drug, wrong route also. For example, you have a very severe pneumonia, you won't be treating it with oral antibiotic, isn't it? Right? So these are the things that should come to your mind. So in this child, what antibiotic? I know what antibiotic he received. He received good dose of amoxiclav outside. That's very important for us in the discussion. He received 80 mg per kg of amoxiclav outside parenterally for 2 days. He has received. And this boy, from the history, the fever never came down. Right? Never came down. He continued to be toxic. He started vomiting. In fact, as per the history, he never improved after about 48 hours. That is when he was referred. Right? That's what has happened. That's very important. That history is very important. Right?
Go for examination.
On examination, child was comfortably sitting on the cot, not looking toxic or requiring oxygen supplement, with IV line in the right dorsum of the hand, no obvious severe respiratory distress. There was no pallor, icterus, sign.
No obvious severe respiratory distress. What do you mean?
Sir, use of accessory muscles, scalene muscles, sternocleidomastoid muscles, nasal flaring, head bobbing or severe distress.
Okay. So signs of severe respiratory distress includes your head bobbing, grunting, hypoxemia and altered sensorium or altered mental status. Okay, that means that is a severe respiratory distress. Okay, fine. Then
there is no pallor, icterus, cyanosis, clubbing, edema or significant lymphadenopathy.
Okay. What you said significant lymphadenopathy? What do you mean by significant lymphadenopathy when you said?
Sir, any lymph nodes, cervical lymph nodes more than 1 centimeter or inguinal lymph nodes more than 1.5, cervical more than 0.5, axillary more than 1, and inguinal more than 1.5, or any tender lymph nodes matted or with sinus discharge.
Okay. So anybody from the audience, what do you mean by significant lymph node? Pardon, I think you had a case discussion earlier also. So what do you mean by significant lymph node enlargement? What is the size in the various groups? Come on, one at a time.
Cervical more than 1 centimeter and axillary more than 1, inguinal 1.5, and any 1.5 any
Inguinal
matted
more than-
nodes or any sinus.
Okay. What about epitrochlear?
Multiple sides, epitrochlear, any side.
Okay. Fine. Then
Any epitrochlear or supraclavicular lymph nodes is significant.
I think the most important fundamental point one must remember is that when it comes to regional adenopathy, size is important. When it comes to generalized lymphadenopathy,
size does not matter.
size doesn't matter. I mean, it is just like remembering, if there is a small disturbance in Nungambakam area, you don't worry. Unless it is big, you don't worry. But if there are small disturbances from Kashmir to Kanyakumari, even there are small disturbances, it must be a national problem. So very similar to that, if the generalized lymphadenopathy, even if the size does not qualify to be called as significant lymphadenopathy is there, it must be considered significant unless otherwise proved. For example, you have a child with a leukemia, you may not get lymph nodes of 1.5 centimeter in the neck or in the inguinal region. You may get only 0.5, but you will find it everywhere, including epitrochlear, sometimes even posterior occiput. So that is a very important fundamental point you must remember.
Vitals, pulses of 98 per minute, all peripheral pulses well fed, good volume.
Pallor, icterus, cyanosis, clubbing, lymphadenopathy. Then what about the other general examination, the head to foot examination?
Head to foot examination, head is normal in size and shape. Eyes are normal, no conjunctivitis. Ear pinna and mouth oral cavity is normal, sir. No cleft lip or cleft palate. Face appears normal. No allergic sinus or no allergic salute. No enlarged veins or swelling over the neck. BCG scar is absent. There is a mark over the left arm. Chest appears normal with no retractions, no accessory muscle involvement. Abdomen, external genitalia and limbs are normal, sir.
Okay.
Anthropometry, weight is of 31.5 kg.
Head to foot examination, vitals, then anthropometry. What about the vitals?
So pulses of 98 per minute, all peripheral pulses well fed, good volume with no radiofemoral delay. Respiratory rate of 46 per minute, thoracoabdomen.
Okay, you say respiratory rate of 46 per minute. In your opening statement, you said the child does not have respiratory distress. For a 10-year-old boy, respiratory rate of 46 per minute is normal or abnormal?
Abnormal.
Okay, then why did you comment on the generalized examination? Your opening statement said that child does not have any respiratory distress.
Comfortable but not dyspnea.
Severe respiratory distress like head bobbing and all those.
How often you see head bobbing in a 10-year-old boy? Huh? He'll be in the ICU if he has got head bobbing. I don't think. Again, it's very uncommon in older age group. Head bobbing is a very significant sign indicating severe respiratory distress. I think grunt and head bobbing and working at the ala nasi are very sensitive indicators of the likelihood of hypoxia in a young infant who has got pneumonia, not in an older boy like this. Right? An older boy like this, he could have hypoxia only in the presence of tachypnea. Tachypnea. In fact, it is said that during the H1N1 epidemic, many adults who had severe complications were the ones who did not even perceive they had respiratory distress. Many of them used to have what is called quiet tachypnea. They were unaware of their the severity of illness, but when they had checked the pulse oximetry, it was found to be very low. Quite a few had gone into ICU. Viral pneumonias are notorious in causing hypoxia without much of respiratory distress. Of course, in this age group, viral pneumonias are extremely unusual.
Did you check the respiratory rate for him?
Sir, the wash bed. So now opening
Demonstrate how you check the respiratory rate.
Come on. So, okay. Anyone from the audience, can you please come and examine his respiratory rate? Come. We want volunteers. No. Come on, Manoj, come. Ukanduko. Just could you please check the respiratory rate of this boy? Okay. Okay. Yeah.
And I would like to place my hand over the abdomen, and I would like to count for 10 seconds, and I would like to.
It's a respiratory system case.
It's
a long case. Would you like to count for 6 seconds and multiply by 10?
For the 1 full minute I will count.
Okay.
And I'll see how many times my palm moves out, and I'll calculate the respiratory rate.
Place your hand properly.
Over the abdomen.
You counted for 1 full minute? You have never looked at your watch? See, this may be an OSCE station, right? Please examine the respiratory rate of this boy, right?
I'm going to stop you, Manoj. Please continue. Please, can anybody in the audience point out what mistakes he is making? Huh? What's the most striking mistake he is making? Okay, let me do it, and you see what mistake I am making. Huh? You must have the watch as well as the chest in the same field of your vision. Otherwise, you will never be able to count the respiratory rate. Commonest mistake. You are only doing it for the sake of doing it. If you are doing like this, you would have seen many doctors, putting the hand on the pulse. Everything is fine. Okay, it's almost like that. Doesn't make sense at all. The watch should be preferably kept away from your hand and held at the same plane as you inspect the chest. Please do that.
What type of breathing is having? Normal?
Mentions.
Okay, you have not made mention. Especially in respiratory case, respiratory rate, don't stop with telling respiratory rate. You should always tell respiratory rate is this much, what type of breathing, whether the child has got any other retractions or any features of respiratory distress, and if facilities are there, pulse oximetry should be considered as a marker.
It is 35 per minute.
35 per minute.
Normal or abnormal for this age?
This age is abnormal.
Abnormal. More than?
30. For this age, it's more.
Can you tell me what is defined tachypnea?
Different tachypnea in various age groups.
For a child who is for infant who is less than 2 months of age, it should be less than 60 per minute.
So more than 60 tachypnea.
More than 60 is tachypnea. And more than 1 year of age.
2 to 12 months.
2 to 12 months, it is more than 50. And then more than 12 months of age is more than. Up to 5 years is more than 40.
Okay.
Then more than 5 years it is more than 30.
Okay. Thanks Manoj. Yeah, Samira, proceed.
I think one other important clue to the presence of tachypnea in an older child will be the ratio between the respiratory rate and the heart rate. Because you can't, even if it is 28 for an older child, it may still be considered as high. But if the child doesn't have fever and doesn't have much of tachycardia, the 4:1 ratio is altered. For example, you have normally a ratio between the heart rate and the respiratory rate as 4:1. That becomes the norm in an older child. That ratio is altered. For example, it becomes 4:2. The respiratory rate is high. That could give an indirect clue even if it doesn't satisfy the numbers. The WHO, for convenience for field workers, has not defined tachypnea above the age of
5 years.
5 years. 5 years. Right?
Present.
BP of 102 by 66 mm mercury in right upper limb measured in sitting position. Child was afebrile at examination with saturation maintained 98%.
Okay.
Saturation maintained 98% in room air.
Okay.
Anthropometry weight is 31.5 kg, which comes between comes at the 58th centile, and height of 150 centimeter. It comes between 75th to 97th.
How old is he? He's completed 10 or he's into 10?
10s.
He's completed 10.
Started 10s.
So 9.
So 9 years.
9 years completed. Okay, fine. Okay. So up to what growth chart did you use for him?
So I checked both with WHO and CDC charts.
Okay, fine.
WHO charts are universally accepted.
Yeah.
Anyway.
And recently, for the WHO charts, the weight for ages up to 10 years of age. Recently, our Indian Academy of Pediatrics have come out with a new growth chart that has been published in the January issue. Okay, it gives weight of the child and the centiles for up to 18 years of age. Okay, so just make sure you all go through that, right?
And BMI of 14, sir, which comes between 3rd to 15th centiles.
Okay.
12 to 15.
Third
to 15.
He's a 3rd to 15th centile. Fine. Then.
So coming to respiratory examination, sir.
Okay.
Coming to respiratory examination, upper respiratory tract examination, ears bilateral wax is present, nose DNS to the right is present with convexity to the right, throat and oral cavity examination is normal, no tonsillar enlargement, no pharyngeal inflammation, no bad odor from the mouth, sir.
Halitosis in this age group, what are your differential diagnosis?
Bronchiectasis, lung
Okay.
abscess.
Bronchiectasis and lung abscess, fine. Then
Even sometimes dental caries.
dental caries or poor oral hygiene. Okay, fine. Then
Coming to inspection, the shape of the chest is normal with no pectus excavatum or carinatum.
we'll come down and as you see, you just run through your findings.
The shape of the chest is normal with no
Okay.
pectus excavatum or carinatum.
Okay,
Bilateral movement of the chest appears normal.
Okay.
Trachea appears to be in midline with apex beat in the fifth intercostal space in the mid-clavicular line.
Apex beat or apical impulse? What do you comment on it?
Harrison's sulcus in this boy.
No, sir.
Where do you look for Harrison sulcus? Will you please demonstrate?
At the lower costal margin.
Okay,
sir.
just
The insertion of the diaphragm.
okay.
What does
That
it
way the-
signify?
It signifies a increased diaphragm. It usually appears in
Chronic problem.
chronic problem or in
Chronic problem.
rickets.
Fine. Then you said apex beat.
Apical impulse.
Apical impulse is an inspectory finding. Beat is a palpatory finding. Fine. Then
Apical impulse in 15th intercostal space in the mid-clavicular line. Spine appears normal with no scoliosis or kyphosis.
okay.
No visible pulsations, no dilated veins over the chest, no use of accessory muscles, no subcostal intercostal retractions.
Okay.
Coming to palpation,
Flattening of the chest, notice, no obvious localized bulging. That's like you
Is there
mentioned.
any flattening or fullness of the chest in this boy? Is there any flattening or fullness,
no, sir.
and is there decreased movement in one side in this boy?
On examination, no, sir.
You are talking only examination.
Sir, on
Inspection.
inspection, no, sir.
No, you didn't mention. In the inspection, I didn't hear you mentioning about any flattening or prominence, fullness. That is very important. Second thing is, you didn't say whether the movements by inspection are symmetrical or asymmetrical.
He made a mention both symmetrical is there.
Equal.
Yeah.
Why don't you look and demonstrate and show me how you look for equality of movements on both sides? Inspection. I am not convinced that by inspection the movements are equal and bilaterally symmetrical in this side.
So on inspection, looking behind standing behind the back of the chest, I look for the movement of the upper part of the chest, whether both sides are moving equally, and also when in supine position, standing at the horizontally at the level of the chest, on the lateral side, and also at the foot end of the bed, I look for bilateral movements.
Please demonstrate. Please demonstrate. No wonder. Even if you mix inspection with palpation, it doesn't make a difference. Will you please demonstrate the chest movements?
You need not tell, you just demonstrate.
Anteriorly, look for the outward movement of the chest wall with each inspiration, and also standing behind the child, I look for the movement of the apex or the upper part of the chest, whether both shoulders are moving equally. Then in supine position. In supine position, I'll bend down to the level of the chair, and in lateral position, I'll look at whether both sides are moving equally, and also at the foot end of the bed, I'll look at bilateral symmetry. Inspection. Yes, sir. One is standing behind the child. Just place my warm hands over the upper part of the chest,
And what you are looking for?
And I'm looking for the movement upward here of both my hands.
Both my thumb.
Hands or
Thumb.
both thumbs?
Thumbs or hands. Then
Movement up and down or horizontal?
up and down.
Up and down.
And the
Front?
second method is sitting in front of the child. I place both my hand over the anterior part of the chest.
To demonstrate.
I place my hand both over the anterior part of the chest and look for the outward thrust of the bilateral sides.
Is that how you do it? Outward thrust you see or lateral?
Just is expanding in which direction?
Outward.
Could you please demonstrate that?
So, upper part of the chest, but the movement of the hands, which is moving more.
Okay, lower
right
part.
and left. And lower part, inserting
Yeah.
the chest,
Okay.
and stretching the thumb to the full, and keeping the fingers, thumb at the midline, equally placed.
Okay.
Then I'll ask him to take normal breath.
You ask him to take a normal breath.
It is less on the right side compared to the left side.
Is it so obvious really here?
It's obvious.
It's obvious. And also,
Nice. Nalla moochu iltudu once more. Nalla moochu iltudu. So there is a diminished movement in the right lung, expansion of right lung. Okay, from your this thing. Fine. Okay, fine.
For example, if there is an obese kid, for this child who is thin built, you are able to approximate your thumbs and do it. For example, there is an obese kid, still you want to see. How are you going to demonstrate? Sit like this, facing the camera. Any idea? Just hold the mic for me and just. If there is an obese kid, this is how you are going to do. Apical, it doesn't change. You are going to see only the up and down movement of the thumbs. But if it's an obese kid, you just put your thumbs like this and try to approximate your thumbs, putting in 2 or 3 skin folds in between your thumbs, so that whichever side is normally expanding, that side, the folds will start disappearing or obliterating, and then the side whichever is still in the pathological thing, that side the folds will not disappear. That means the child is not able to expand well enough to folds to disappear. That's how you do it for an obese kid.
If you carefully see, Samira, it is very obvious that the movements in the upper zones, both sides are pretty equal. On the other hand, particularly in the back, below the scapula, the movements on the which side, right or left? Right, when compared to the left, are reduced, indicating that the right,
Is probably on the right
probably pathology is in the right
lower lobe.
lower lobe. It's very obvious if you carefully observe. Nalla moochu eduthudupa. Nalla moochu eduthudu. Yeah. You will find that the left scapula is moving much better than the
Right scapula.
right scapula. And particularly the movement laterally is much more in the right scapula than in the infrascapular region. And one, suma loose out, put nalla loose out, nalla sadharana out, rendu kai ipdi vechuko. Sadharana moochu irukada. And even when he is breathing quietly, the infrascapular region on the right side is moving much less than the left side. Indicate, even without touching, you can now localize the lesion to the right lower lobe. Right?
Go for palpation. Palpation.
Palpation, trachea is in the midline.
Okay.
Apical bit is present in the fifth intercostal space at the midclavicular line. Movement is decreased in the right mammary, axillary and subscapular regions.
Okay.
How do you know that trachea is in the midline by palpation?
We should ask the child to look forward. You have to keep each fingers over the one type of examination is to trace by the index finger the trachea and the midline, and then insinuate on the lateral side in between the sternocleidomastoid muscle and the trachea. Similarly, with the other thumb, we have to trace the trachea and insinuate between the sternocleidomastoid and the trachea on the other side, and we have to see the distance between the sternocleidomastoid and the trachea.
And you will also feel the resistance of the finger to be insinuated. So the whichever side the resistance is being felt more, that side the trachea is being shifted, right?
And please know the theory behind this trail sign. Okay, maybe a question. Fine. Then next.
Per patient, AP diameter was 13 centimeter and transverse diameter of 22 centimeter.
Can you demonstrate how you do it? AP and transverse diameters.
I took a help of an assistant with two cardboards.
Okay.
Kept.
Okay, you tell first, and then we can demonstrate.
First is transverse diameter. You should sit straightly. Child should sit straightly, looking forward. And each hard-bound book or a hard material cardboard should be kept on either side below the axial ulcer, and then the medial distance between the two boards. And similarly, for the anterior posterior diameter, we have to place a cardboard in the front and at the back at the level of the nipples and in between the wrench.
You want to do it, Rahul? Just do it, no? Just now he has told. Good on ignore. No, that he has explained. You just demonstrate now. That's enough. Samira, he is helping you out. So why don't you measure?
To measure between the inner borders, keeping it straight, we have to measure between the inner borders.
Fine, that is done. Then what about the transverse diameter? He's an older child, so you can ask himself to grasp this one in his axilla.
Like this. On the side of make sure that both are parallel, both boards are parallel.
Yes, that is more important. Make sure that both the cardboards are parallel to each other. Okay, most of the times they will come coming into an acute angle because of the pressure. Just avoid it and measure it.
Being parallel, we have to measure the inner distance between the.
Fine, that's it. Yeah.
So fast.
Inspection, you didn't tell about a man to test being done.
In general examination.
Right, done.
Coming to percussions.
Yeah.
Percussion.
No, palpation still something else is there. You have measured the diameters fine. What about the chest expansion? Equal or not you have seen with the thumbs and with the fingers and with the skin fold thickness. But what about the expansion on each side and total expansion? That also you need to tell. Okay.
Chest measurements. Okay.
Chest measurements, right.
On percussion, stony dull note is heard over the right inframammary, axillary,
please
and the interscapular and subscapular area.
The correct term is stony dullness is perceived. It is often said that the percussion note should not be heard; it should be perceived. In fact, a stony dullness cannot be heard; it can only be perceived by the finger. Your finger will be painful. That is stony dullness. So it is not heard. Others cannot feel the pain, cannot hear the pain. So it is perceived.
Could you please demonstrate? Don't do direct percussion, just do only the indirect percussion.
First, start with the apical area, cornix isthmus, just above the clavicle. Then we'll start from the each intercostal space. First, direct percussion over the clavicle. We will directly percuss.
The supraclavicular region should be from the
behind. So all of you learn this principles and technique of percussion. Okay, in exam they will be asked to demonstrate, right?
And the pleximeter should be in intercostal space. Don't keep it on the ribs. You'll not be able to hear it, right? Yes. Correct.
Inframemory we perceive the dullness.
Okay.
Similarly coming to axillary area. Kai மேல் வெச்சுக்கோ ரெண்டு சைடு செக் பண்றோம் in the intercostal space bilateral.
Audience, what is the one good thing which he is doing perfectly? He is alternating his hands onto the right and left. Always it should be a comparison between the right and left. Many times the students make a mistake of doing it all on the same side and then going to the opposite side, which will be a wrong thing to do. Yes, here dull note is there. So what do you infer by hearing a dull note in the right infra-axillary region? How do you prove that it is not liver? Dr. Dhanlakshmi was asking you whether it is a liver. She says that it is a liver. How are you going to prove it?
By tidal percussion, sir. We'll take in.
Demonstrate. She wants to demonstrate.
First, we'll percuss from above and locate the maximum upper border of dullness, and then we'll ask him to take a deep inspiration. And then we'll recheck at the same position.
Okay. If
the dullness still persists, then it's an effusion.
Okay.
If it disappears, then it was a liver.
What is the similar dullness or tympanic node which is seen on the left side called?
Trops.
Space. Usually it is occupied by the
stomach fundus.
Yes, fundus of the stomach. Tympanic node.
It is decreased if it's obliterated when there is pleural effusion.
Pleural effusion. Excellent. Right. Auscultation findings.
Auscultation findings is decreased breath sounds in the right inframemory, axillary, interscapular and subscapular region. There are no added sounds like wheeze, crackles or stridor. Vocal resonance is increased in the right memory, no wheeze or crackles or stridor. Stridor is not. Sorry. Vocal resonance is increased in the right memory area, which also has a bronchophony and a whispering plectolochies.
Okay.
Present in the right memory area, and the decreased vocal resonance in the right axillary, interscapular and subscapular area.
So could you please sum up your physical examination findings?
Decreased vocal resonance.
Decreased vocal resonance in the axillary and the subscapular and interscapular area.
Now summarize your cardinal history, cardinal examination findings alone, and give us a diagnosis or a differential diagnosis.
So the 10-year-old child presenting with fever of 6 days duration, which is not subsiding, it's persisting with cough since 4 days.
Again, don't go for history of presenting illness. Summary is a child, a 10-year-old boy presented with 6 days fever and cough. That's all. Okay, on examination.
On examination, child is tachypnic.
Okay.
With
he is tachypnic. Always.
He is tachypnic with no use of accessory muscles or intercostal retractions, with the trachea and the apical impulse in the midline, so
okay.
Not shifted. With decreased movement on the right side of lower chest, that is memory and the subscapular region. So probably lower.
Decreased lower chest movements. Okay, then.
And on percussion, stony dull.
Okay. So there is a dullness on percussion, especially in the right lower lobe areas. Then.
And increased vocal resonance in the memory areas.
Okay, fine. Yes, stop with this. Yes, audience. Nagavini, with this history and physical findings, now what do you think is the diagnosis?
Can you repeat your auscultatory findings? Can you repeat your auscultatory findings? Repeat. Abnormalities only you tell me once more.
Sir, there is decreased breath zone in the right.
Decreased,
sir.
Yeah.
In right inframammary.
Okay.
And axillary, inter and subscapular regions.
Okay.
Vocal resonance is increased in the right memory areas with whispering plectrophy and bronchophony in the right memory areas.
Anybody wants to comment on this from the audience? So something which is not correct in what he said. Can anybody tell me what is the problem? Anybody?
If it is a bronchial breathing, then we can hear the bronchophony.
Basic rule, if you have increased vocal resonance, you have to have bronchial breathing.
And with the
Right?
decreased breath,
Probably the mistake Samira has made, he has compared the right memory and the left memory. Left memory has the heart. The vocal resonance will be relatively less. Right? So you cannot have bronchophony and egophony unless there is bronchial breathing. So rule of thumb, if you say in fact it is the other way. If you are very sure there is bronchophony and egophony, even if you hear normal breathing, you can say it is bronchial breath sound. You cannot have a child who has only increased vocal resonance, very significant. He said whispering activity also is present. You cannot have it unless there is bronchial breathing. That's a very, very important point you must remember. Right? And another thing is, sometimes one of the commonest problems that can arise in a child who has got a pneumonia, if you have a doubt about bronchial breathing, you should ask the patient to do something. What is that? Cough. Put the kerchief or a towel, ask him to close the mouth and cough. In fact, we will try to do that. Will you try to do that, Samira? Then auscultate whether you get bronchial breathing, you can demonstrate. Ask him to use it. Yeah. No, unbutton just once. Auscultate. Because if you have, is there a bronchial breathing?
bronchial breathing illa sir, but definitely VR is increased.
Not possible. That's the perception of, it is a problem of perception. When compared to the mammary area on the left side, it will obviously be more. It cannot occur.
So now what is the differential diagnosis? Nagavini. So correlate the history, correlate the physical examination findings, and then now give your diagnosis.
According to the history, there is parenchymal and pleural in.
You need not elaborate. She has already said.
If somebody hears increased vocal resonance and bronchial breathing over the mammary area, what's the diagnosis? Right side.
Consolidation.
Consolidation where?
Right.
Middle lobe. Remember, over the nipple, over the mammary area, it's very characteristically the middle lobe on the right side.
Consolidation with pleural effusion.
Consolidation with
pleural effusion.
What are the features to say it is a consolidation? What are the features to say it's a pleural effusion?
There is increased vocal resonance and bronchial breathing with whispering pectoral loci over the mammary area and right mammary area, and right infraaxillary subscapular area there is decreased air entry with decreased chest movement and decreased vocal resonance indicating pleural effusion.
Fine. How do you want to manage this patient? Wahid. How do you want to manage this patient?
Sir, first of all, chest X-ray.
First of all is chest X-ray. Okay, fine. Yes.
And
so when a question is asked how to manage, always divide. Investigations that are used to confirm my diagnosis and investigations that are used to support my diagnosis. Okay, fine. What investigation you do to confirm your diagnosis?
Sir, chest X-ray.
Okay, chest X-ray. What are the features in chest X-ray? Could anyone of you please get the X-ray of this patient?
Sir, any consolidation?
Okay, consolidation. Fine.
Any effusion?
Effusion. Fine. Okay, suppose this boy has got a effusion. Okay, there is no mediastinal shift. What is the problem? Logical explanation that you can give.
Mostly.
This boy has got a effusion, but he has not got any features of a massive effusion like a mediastinal shift. There is no bulging of the intercostal spaces, anything. So what an X-ray also shows a thin layer of fluid. What probable logical explanation you can think of?
Sir, it may be synomonic effusion.
Okay. Maybe synomonic effusion. Fine. Then
minimal effusion.
Minimal effusion. Fine. Then okay. What other investigations will you do? Okay. Full blood counts to rule out?
To bacterial infection.
Okay. Fine. Then
Related effusion or looks like empyema. So tapping, pleural tapping we can do.
Other investigations.
Sir, pleural tapping we can do if there is.
Diagnostic pleural tapping you can do. Fine. Then
sir, blood culture rule out.
Okay, blood culture.
Bacteriemia.
Then
Would you like to do a renal function test here? If so, why? If so, why not?
Sir, at present, a child is not that sick looking. Child is clinically stable, and there are no other symptoms of any renal involvement.
No, if at all, if you are going to do an RFT, what is your idea behind doing an RFT in a pulmonology case, the case of respiratory system?
To rule out hyponatremia, pneumonia can cause SADH.
SADH.
Exactly. SADH is a good possibility even in a case of pneumonia, so you need to do RFT also.
Okay, fine.
You said pleural tap. For example, if it is serous sanguineous or hemorrhagic, how can you confirm it that it is really a hemorrhagic pleural effusion? How do you confirm? One tap you cannot say that it is hemorrhagic effusion, right? It could be a traumatic tap also. So how do you differentiate a traumatic tap and a hemorrhagic pleural effusion? Anybody from the audience? So the hematocrit is consistently above 50% of the blood hematocrit in a pleural effusion, then you say it as a hemorrhagic effusion. Otherwise it could as well be a traumatic tap of a single episode, right? Then once you take the pleural tap, how do you differentiate an exudate and a transudate? Yes, tell me, you only.
Concentration within the should be greater than 2/3 of the in the pleural fluids. It's greater than, compared to serum level, it should be greater than 2/3 of the level. Then and serum LDH level should be greater than 2/3.
Okay.
Cell count, cells.
Okay, cell count. Any ratios are important? What about serum and pleural fluid and serum LDH, pleural fluid and serum protein ratios?
Greater than 0.66
and 0.5, suggestive of exudate. Okay.
I think a few important fundamental points need to be remembered. One is that blood cultures. Can anybody tell me what is the percentage of positivity of blood cultures in pneumonia? Our ID consultant is there. I'm sure she would be able to throw light on it.
10%.
Yeah,
Only 10% of the children with pneumonia will have
there are
positive
some
blood
review
culture.
articles which conclude that there is no need
If you
to
are
do blood
treating as
culture.
OPD, there is no need to do a blood culture.
That is number one. Number two, complete blood counts also.
Look for anemia to see for autoimmune hemolytic anemia associated with atypical bacteria, mycoplasma. That's also important.
Yeah, but on the other hand, if you have leukocytosis, extreme leukocytosis,
it favors bacterial.
Bacteria, specifically
pneumococcus.
I think that's, not that all these tools are useless.
If it is 40,000, definitely most probable chances, most likely pneumococcus.
Pneumococcus, that's number 2. Number 3, similarly.
And now the guideline says if you have no focus, no cough, only fever, if you find extreme leukocytosis, that is the total count is more than 25,000, then you are justified in ordering a chest X-ray.
X-ray chest has
for focus.
If there is no focus, more than 25,000, X-ray chest is
indicated.
It might give you a clue of pneumonia, particularly pneumococcal pneumonia. Similarly, if you have a low hemoglobin, it could indicate the possibility of mycoplasma pneumonia, which is notoriously associated with
autoimmune hemolytic anemia.
Then similarly, CRP, the most of the guidelines say it has no place in the differentiation between bacterial and viral pneumonia. But however,
if
it is very high, the possibility of pneumococcal pneumonia is very high. Pneumococcal. That doesn't mean every CRP which is high means pneumococcus. That's one. And there are some studies which have shown that procalcitonin might differentiate better, but they have not been validated, not found to be useful.
And one more test can be done in urine. Anybody can name? Urine? To look for? Pneumococcal antigen. And one more, urine.
Chlamydia also.
Chlamydia also can do.
That urine you can even do Legionnaires also. Antigen. You can do urinary pneumococcal antigen, urinary chlamydia, urinary antigen for Legionnaires also. Each has its limited role. Right? Other thing, Sumant was asking about electrolytes in pneumonia, because however rare it is, literature mentions that if you have hyponatremia, it could indicate the possibility of Legionnaires pneumonia. In fact, Legionnaires pneumonia we hardly diagnose because it's not commonly looked for, and it's not common in pediatrics and compared to adults. But it is said that if you have a child who has altered sensorium or drowsiness, who has hyponatremia, and who has diarrhea, and who has an atypical pneumonia, it is very much like these 3 things are mentioned in literature: hyponatremia, diarrhea, and some alteration in the consciousness in an atypical pneumonia could indicate it could be Legionnaires pneumonia. Right? But then none of these factors, none of these features can reliably give the etiological diagnosis for pneumonia by and large. For example, you have leukopenia, it doesn't mean it's viral. You have lymphocytosis, it doesn't mean it is always viral. So they do not reliably distinguish between viral and bacterial pneumonia. I think you can take up the questions one by one. Ganesh, you can take the first question.
Still we are not finished the management.
Okay, fine.
So, okay, we have done the chest X-ray. This is the X-ray of this boy. Can any one of you come and please read the chest X-ray?
Sorry, yes, we'll put the, we'll make use of TV as the lobby here. Able to see? No? Under the light, huh? Okay.
Samira, read the X-ray.
Read the chest X-ray, Samira. Put in all the 9 points which you read in a chest X-ray. Okay.
With most not rotated film, central film with adequate exposure.
Okay.
Just adequate exposure.
Okay.
With opacity over the right lower lobe.
Okay.
And non-homogeneous opacity in the right lower lobe with
are you seeing any difference in the lucency between the two sides, right and left? In toto, if you see, just mentally block the mediastinum and heart and compare the both sides, which is more lucent and which is less lucent.
This decreased lucence in right sides.
Yes. What does it suggest? It suggests there is a thin film of fluid which is there on the right side. Okay.
Yes.
Right. Next.
Costophrenic angle is mildly.
Okay. Costophrenic, which is costophrenic, which is cardiophrenic.
This is the costophrenic and this is the cardiophrenic.
Cardiophrenic angle. Okay. If each of them is obliterated, what is your inference on that?
It indicates probable effusion.
Yes, costophrenic is obliterated, it is usually an effusion. If cardiophrenic angle is obliterated, it could even be a
pericard,
subsegmental atelectasis, or even a consolidation, or if right heart of the body is obscured, then probably we are dealing with the case of right middle of the
Silhouette sign positive, Samira? And what's the significance?
What is the significance of silhouette sign? Is it positive there?
Silhouette sign is whether we can make out the right border of the heart clearly. No ma'am, it indicates middle lobe involvement.
Yes. And what about usually the right heart of the border has to be seen, no, somewhat, but here is it seen?
Yes, 1 moment, Sumant. If you are able to see the right border of the heart in contrast to the opaque shadow in the lung, that means the shadow is likely to be behind the heart. That is likely to occur. It can occur in the left lower lobe or in the right lower lobe. But if you are not able to see, that means it is adjacent to the heart. That is the genesis of the silhouette sign.
Then what about the bony cage? Bony cage seems to be normal. Right.
No cardiomyopathy.
This was the X-ray which was taken at the time of admission in an outside hospital. X-ray was repeated because he did not improve, and this was the X-ray.
The silhouette sign is positive, and now the opacity is more homogeneous, and the costophrenic angle is lost in this progressing effusion.
So there is a progressive pneumonia as such. And what about the costophrenic? And do you see the pleural effusion is more here?
More so costophrenic angle is obliterated.
Yes.
Even the cardiac.
Okay. For example, if you see this, and then how?
You can see the line here, pleural reflection.
Pleural reflection is also seen, and usually for a standing film, how much fluid can you expect to be seen in the chest X-ray?
More than 200 ml.
Yes, at least 400 ml should be there for it to be picked up. And for example, if it is less than that, how are you going to diagnose? But clinically you are sure it's a pleural effusion.
You have to place in decipitous position.
Lateral decipitous position. Even 50 ml can be picked up. Okay, right. What else in the chest X-ray? Based on that, are you going to go in, or you want any other investigation before going in?
I want to confirm with an ultrasound effusion.
Okay, ultrasound. By doing ultrasound, what else will be giving you? What else other information can you get? You can get information about loculations and exact point where you can go in also, right?
Yes.
So now the diagnosis is right lower lobe consolidation with minimal pleural effusion. You want to start treatment for this patient. Fine. Audience, what treatment you want to initiate?
What is the drug of choice in community? It's pneumonia or severe pneumonia, first of all. It's pneumonia, only tachypnea. There is no retraction. So tachypnea, so it's pneumonia. So community acquired pneumonia, what is the first line of choice? Amoxicillin. So what is the dose? 80 mg per kg per day. So this child was previously hospitalized outside, given treatment amoxicillin for 2 days, and then in view of persisting fever, cough, and we noticed tachypnea. So we are admitting the child. So what you want to start? Ceftriaxone. Ceftriaxone. Why? It's only pneumonia, no? So what you want to start?
Anybody? Come on.
That means it is severe or very severe pneumonia. You are telling ceftriaxone means?
Severe pneumonia, you can start with ceftriaxone. So it's pneumonia only. And he has no distress or no hypoxia. So we can start with amoxiclav. So any other thing you want to start? Azithromycin, macrolide.
Why not give only amoxicillin?
This child was treated outside, sir. 2 days, not like persisting fever. We cannot comment at 48 hours, the child has not responded. In some pneumonia, fever can be there, but child is clinically improving. If the tachypnea is not there and only fever, child is non-toxic, able to take orally, playing child, you can continue with amoxicillin. Sometimes fever will take even 4 to 5 days for the fever to settle down. So only
what point of time will you decide to change an antibiotic if you have started amoxicillin for a child who has got
Sir, we have to
pneumonia?
give some time, 72 to
How much time?
72, 3 to 4 days. If the child is not deteriorating, only fever, then we can wait. We can wait.
In this child, what will be the antibiotic of your choice if you had seen this child? Initially and now. Suppose this child with this X-ray.
Given amoxiclav outside 2 days.
No, in this child.
Initially, if I have seen, I will start with amoxicillin.
Suppose I have decided to give him only azithromycin. He is not toxic. He is an older boy.
So, but
even now he is not very ill. He looks like having a walking pneumonia.
Till now in this age group, pneumococcus is the most common. And guidelines are clearly giving some guidelines.
What is the harm in giving only azithromycin to such a child?
That's what we cannot be sure, no. And it's a bacteriostatic drug. It's not a cidal drug. And there are some guidelines. Whenever you have some extra pulmonary complications like hemolytic anemia, seizures, glomerulonephritis, you are justified in giving azithromycin. Or when you have prolonged low-grade fever, cough is the predominant symptom and there is no consolidation on the chest X-ray and perihilar sticky infiltrates, then you can give azithromycin. That too, in these two conditions, they are telling you combine with a beta-lactam antibiotics like amoxicillin or amoxiclav. And one more condition is if the child is fully immunized against Hib and pneumococcus, fully immunized child but developing non-suppurative complications. If suppuration is there, again it's less chance to have mycoplasma as the etiology.
I think one of the important points that you must remember is that if you are treating pneumonia only with the macrolide, there is a small chance that you will not be able to treat bacteremias due to pneumococcus or H flu. So, in a child who is toxic, who could have the possibility of bacteremia, even if you clinically want to give a macrolide, you should always combine with a beta-lactam. Macrolide alone should not be given to treat any child with pneumonia who is likely to have a bacteremia.
Consolidation. If you have only low-grade fever, cough and sticky infiltrates, maybe you are justified in giving only azithromycin. But if you see consolidation on the chest X-ray,
what are the situations in which you can definitely say it is a typical pneumonia looking at the X-ray? And on the other hand, what are the situations in which you will think it is atypical pneumonia?
Atypical pneumonia, if there are no obvious focus of consolidation, only perihilar sticky infiltrates and symptoms are more than the signs. They will have more cough rather than other symptoms. So then atypical we can think, and extra pulmonary manifestation, then you can think of atypical organism. And typical in the sense, if you have pneumatocyst, it's unequivocal evidence of a staphylococcal disease. And empyema also most likely bacterial. But sympneumonic effusion, 25% of atypical pneumonia also can have sympneumonic effusion. But looking at the sympneumonic effusion, you cannot clearly differentiate.
Samira, is this empyema thoracis? Fluid has increased. Fever is continuing.
No distress.
Because child symptomatically is better, sir. Not toxic.
Yeah. There is no chest wall tenderness. There is no edema. Child is not toxic. And he is not an immunocompromised individual. So the possibility of empyema definitely does not exist. Right? Shall we take the questions from the audience? Yeah.
To sum up, what Dr. Samir has presented today, he has presented a 10-year-old boy who presented with an acute onset of a febrile illness and cough, where fever is the most predominant symptom followed by cough. On examination, this boy had a feature suggestive of a effusion, and X-ray revealed features suggestive of consolidation with minimal amount of pleural effusion. Has been initiated on appropriate antimicrobial therapy. This boy has been doing well. Okay, so we have just oriented you all towards examination of the respiratory system. A few points I would like to add. Whatever may be at the end, what we are going to assess out of students. One, whether you are able to identify is there a problem or not. Once there is a problem, is it an acute problem or a chronic problem? 3, is the problem progressive, static, or it is improving? Number 4, if there is a problem, where is the problem and what is the site of problem? Okay, fine. After this, what is the probable etiology you will get from the history? What are the risk factors? What are all the comorbid conditions? What are all the complications? And main, what is the parental understanding of the problem and the psychosocial factors? If you are able to answer these 10 questions at the end of your history taking and a physical examination, I think you will be sure pass. Okay, you need not even need investigations to confirm and support your diagnosis. Okay.
Yes, Suman. Does the chest expansion should be measured each hemithorax and total in case of preschool children also?
In preschool children, it is practically not very easy to check the.
I would say practically not difficult, practically not possible.
Yes, practically not possible.
Not possible. Very rarely it is required. Very rarely it is required.
And
on inspection, can we localize apical impulse, someone? Yes, yes.
We should
if it is a thin-walled chest, it should be possible. If it is visible, you say it is visible. If it is obese child, is not visible, you say it is not visible. And if it's an adolescent girl, you don't even talk about visibility of apical impulse. Right? Be careful.
What clinical signs of upper respiratory tract infection would suggest a bacterial infection and warrant an antibiotic without waiting? This I think ID specialist will answer.
Upper respiratory tract includes AOM also. So less than 6 months, if you have AOM, we should give antibiotic. 6 to 12 months, if there is severe AOM, you have to start an antibiotic. What is severe AOM? Non-severe and severe. Then you will say fever beyond 1 or 2. Okay. Severe otalgia. So if these are there, then you can say as severe AOM. Even if it is unilateral or bilateral, you are justified in starting antibiotic. Beyond 2 years, non-severe, you can observe. Observe for 48 hours. If the symptoms persisting, then you can start antibiotics. If the symptoms resolve, then you need not give antibiotic.
Is bilateral?
Bilateral, we can observe. Most likely it is viral.
About 2 years bilateral, recent recommendations suggest you can observe or give antibiotic. Both options are there.
And AOM, then pharyngitis. So what is the common indication for antibiotic in pharyngitis? Which is more common, viral or bacterial? In all age groups. So how will you differentiate viral and bacterial? Fast. Early onset of the associated symptoms, cough, other discomfort involvement, local fever. So temperature more than 101, absence of cough, and dysphagia, unilateral tender cervical lymphadenopathy. These favor bacterial rather than viral. Okay. So what simple bedside test you can do to confirm?
Just one more. 2 unusual things. Abdominal pain. Does it favor bacterial or viral? Anybody? Abdominal pain in a child who's got pharyngitis, exudates. Does it favor bacterial or viral? Bacterial. Petechiae. Does it favor bacterial or viral? Bacterial. I think these are all unusual things. If there is palatal petechiae and if there is abdominal pain, not together, independently, they favor bacterial rather than viral pharyngitis. Of course, age above 5 years is a very important thing, where the chance of bacterial infection are higher.
More likely. Okay. What test you can do to website you can confirm? Rapid test you can do for B streptococcal antigen, and you can start antibiotic. What is the first line for pharyngitis? Amoxicillin. Dose?
Right.
What are the recommendations? So you can even give a single dose, 50 mg per kg, single daily therapy.
And ABR sinusitis, acute bacterial rhinosinusitis. What are the ways sinusitis can present? In children.
Okay, many more questions are coming up. One is when to change the antibiotic in a case of pneumonia. When will you call non-resolving or progressive pneumonia? Dhanlakshmi? I think you already answered. You said you will wait for about 7. It's basically a clinical judgment. For example, if you have a child who has a pneumonia, within 24 hours it develops signs of severe respiratory distress, definitely you will escalate. But basically you wait for at least 48 to 72 hours.
Only should not be taken as a non-response to antibiotics.
Non-resolving pneumonia, what's the definition? When do you call it non-resolving pneumonia?
Beyond the expected period of time.
Or it is otherwise called slowly resolving pneumonia also nowadays. There is no specific definition, but usually acute, subacute and chronic we take it like less than 3 weeks, 3 weeks to 3 months and more than 3 months. But unusually longer pneumonia, longer duration than expected. For example, such a well-looking child. Right now we have seen the case. If this child is taking more than 2 weeks to resolve, then I would definitely call it like a slowly resolving pneumonia, and that too with non-radiological, no radiological clearance.
Importance of factors affecting antibiotic therapy in case of community-acquired pneumonia. Dr.
So
Dhanlakshmi?
previous antibiotic use and the host factor, that is immunocompetent or immunodeficiency, and look for the clue for any etiology like pneumatozyl or anything is there to suggest any etiology.
Underlying conditions like measles, immunodeficiency, right? Previous exposure, right? Importance of tactile parameters, I think it's difficult in young children.
Now it is no more given in the clinical methods books. Tactile vocal parameters is taken off.
As you could make out in this case, even vocal resonance it is difficult. Even in a 10-year-old boy, it is wrongly interpreted. But the chest expansion should be measured on inspection.
How to come out of antibiotic resistance in a case of pneumonia? That is always there in our hands. That's always there in the hands of the clinicians.
Selection of appropriate antimicrobials, the duration, the dosage, the treatment should be taken into consideration.
Always one thing you should remember is the etiology is the same, but each child will behave differently. The severity may be different, but the common organisms are common. So you need not first jump and give a higher antibiotic. Okay, you always start from the baseline. Okay, first line, then if it is not responding, go for the second line. If it is simple pneumonia. If it is very severe pneumonia, then you can start.
Any questions
from
the students here?
And all of you read what are the timetable taken for a normal healing of a pneumonia radiologically. Those are given in any standard textbooks. So etiology of pneumonia, right? Then the risk factors, the timetable for the radiological clearing, the definition of recurrent pneumonias, persistent pneumonias, right? All those things are given in any standard textbooks. Make sure that you read those also, right?
Okay. Thank you. We come to the end of it. Thank you very much.
Thank you.
Hello? We have finished, sir. One more question, sir.